Thank you very much. Thank you very much also for the kind invitation. It's a pleasure to be here. I'd like to talk in the next 20 minutes, 30 minutes about how to avoid complications in pancreatic surgery. Since this is a very important topic, obviously, and I would like to start with one slide saying that you can actually prevent most of the complications of hemorrhage and of pancreatic fistula, and if they occur, you can treat them. And these are the 2 points of my talk to discuss what we can do really to prevent these complications and how to treat them if they occur. Now, I just give you a brief overview of the numbers in Germany. I don't have the numbers in Turkey, but I just share with you the numbers in Germany if you look under controlled conditions. What is the risk of complication in pancreatic surgery? And if you look at the big centers in Germany that do on average around 80 resections per year, you have a fistula rate, I come back to that later, relevant fistula rate of 21%, so that's quite high, and you have hemorrhage of 14%. Again, these are relevant complications, these are not the minor ones, and I'll show you this later, and this results in a mortality of 7%. So if you hear mortality rates way below 5%, this is not the standard in the centers in Germany. Again, if you look at general hospitals, so you take all hospitals in Germany, there's no limit for cases per year you can do in a hospital, and you see average is 14 resections per year, so that's quite low. You have a mortality of 12%, and you can imagine you have also much higher rates of fistula and hemorrhage. And I don't believe this is a specific problem in Germany. I think this is probably throughout most countries that you have higher rates than you usually report in your publications. Now, I want to talk about the definitions. I think this is an important topic. I want to talk about the risk factors, the known risk factors, and I want to talk about the factors we can modify as a surgeon, and this is, of course, the anastomosis. We talk about drugs like somatostatin, we talk about drains, stent therapy, fluid management, and at the end, I just give you a very brief treatment algorithm of what we do if a complication occurs. Now, I guess most of you are aware of this, and I think this has been a very great achievement that the surgeons of the international community came together and defined what is actually a pancreatic fistula. Before, if you look in the literature, everybody defined it differently, and that made it very, very difficult to compare data between centers. And I think this has been a great progress that we now have a common consensus definition that is now widely accepted throughout the world. Now, I just briefly mentioned this. There has been a slight revision. Previously, there was also grade A fistula. This has been abandoned. This is just called biochemical leak. So you measure amylase higher than 3 times the serum amylase, but it doesn't change the clinical management. So this is just a biochemical leak, and this is not any longer a grade A fistula. Then you have, on the other end of the spectrum, you have a grade C fistula, and this is something that is life-threatening, usually with organ failure or with the need to revise the patient again in theater. And everything in between is a grade B fistula. So something that changes your clinical management, most likely needs some interventional drain, but doesn't require another surgery. So this is the updated consensus definition, and this has also been validated. You can see here what has changed to the previous one, and this is some Annals of Surgery paper where they Twitter the most striking changes. So there's some downgrading of the fistula because you don't have this grade A anymore. We see here we have less C fistula with a new definition, and there's a very strong correlation to the hospital cost. So if you have a grade B fistula, this doubles your cost. A grade C fistula, you can see here almost 7-fold increase in hospital costs. Now, similar and only briefly again, there has been a consensus definition of what we call a hemorrhage, and what is important for the bleeding is the time point. Is it within the first 24 hours or is it later than 24 hours? And then again you have a grade A bleeding. You just see the drop in the hemoglobin, but it doesn't change your clinical management. And then you have the grade B, which can be early and mild to severe. So if it's early, it doesn't matter whether it's a mild bleeding or severe bleeding. If it's late, it can only be mild, because the late and severe is the grade C bleeding. And again, you see both can result in a relaparotomy, but grade B, the patient is in a relatively good condition or moderately impaired. Grade C fistula is grade C bleeding is life-threatening. Now, the question is how to prevent these complications. And I start with hemorrhage because I think that's quite easy to answer. How to prevent this? Now we talk about the early bleeding within 24 hours. And I think there are only two explanations for this. Either it's a technical problem, and this can be avoided by careful, meticulous surgery, or it is some clotting problem. So some bleeding that occurs within the first 24 hours should be managed either by taking care of the coagulation or of your technical aspects. And if you have a late bleed, this is most often related to fistula formation and then subsequent hemorrhage. So actually most of the bleeding you can prevent by preventing fistula, and that's why I want to talk most of the rest about how to prevent fistula. Now we know risk factors, and this has been around for a long time, and everybody who's operating pancreas knows this. We know the duct diameter is very critical. The smaller the duct, the higher the risk. We know the texture is equally important. If you have a fatty pancreas, a very soft pancreas, the risk is much higher than if you have a firm and fibrotic pancreas. The BMI is independently associated, independent of the texture associated. We know the blood loss is quite a strong predictor, the intraoperative blood loss. And the type of resection, but I'm not talking about this. We all know that left resection and head resections have different fistula rates. Now, this is a classical study, and I just briefly show you to highlight 2 points. One I mentioned before, the firmer the texture of the pancreas, the less likely is a fistula, and you see here chronic pancreatitis, 5% fistula rate, and on the other side of the spectrum, bile duct cancer with a very high fistula rate. And the second important point of this paper, and you see it's published in 91, so quite old, but the second important point is if you have a fistula and chronic pancreatitis, the mortality of these 5% is low, it's 9%. So even if you have a fistula, most likely you can manage it without further problems. In contrast, if you have a fistula with a soft pancreas, you get quite high mortality rates. So this is the second important message of this paper. Now, how can we prevent this? And the first question to ask is, where do we anastomose the pancreas with? And there has been a long debate, either do it with the stomach or put it to the jejunum, the small bowel. And there have been a number of analyses, but there has been one very good randomized controlled trial in Germany really looking at this aspect, stomach or jejunum. And what you can see here, the fistula rate is equal. So there is no difference in your fistula rate if you do it in the stomach or if you do a small bowel anastomosis. And there was a recent meta-analysis that found, taking everything together, also the non-randomized trials, a very small risk reduction for fistula in the stomach group. But I have to say this is such a small risk reduction of 0.07 that for me the conclusion is clear. The fistula rate is more or less the same if you anastomose to the stomach or the jejunum. What was different, however, was that there was slightly more hemorrhage, grade AB, in the stomach group, and this is also reflecting the personal experience of people who are doing this anastomosis. So there's a little bit more bleeding, but on the other side, the stomach anastomosis is technically easier. So if you have not a lot of experience in pancreatic surgery, it's easier to anastomosis to the stomach than to the jejunum. Now, if you do it to the jejunum, which kind of anastomosis should you do? And again, there are a lot of retrospective series or single-center series, and it's difficult to answer. So there's the duct to mucosa technique, and I think most of the surgeons are doing that nowadays. They anastomose the duct to the mucosa, and then you can do a second layer, and you can do some invagination, where you, for example, in this case, you don't do the duct to mucosa technique. So the question is that better than duct to mucosa? And I just showed you here two larger studies that showed one advantage for the duct to mucosa and one the other way around. So if you meta-analysis, there's no difference. If you do duct to mucosa or a pure invagination technique, the fistula rate combining all data is the same. And some of you might have known that there was a Chinese group that promoted a binding anastomosis, and they reported a 0 fistula rate with that technique, where you just perform an anastomosis actually with only one purse string suture. But there have been other centers trying to reproduce that, and they also report fistula rates more than 25%. So there's no good, strong evidence for any of these anastomosing techniques. So how do we anastomose it? Well, we perform usually an antecide anastomosis, a duct to mucosa, a double layer, interrupted monofilament sutures, It's kind of a modification of the Catel-Warren or Büchler technique for the anastomosis. But again, this is not evidence-based, and I was for some time in Liverpool where we initiated a trial to compare two techniques, the Blumgard anastomosis technique and the Catel-Warren technique, to find out which one is better or superior to the other one, and we will see whether there's any significant difference. Now, the other important point to prevent fistula is somatostatin, and probably most of you are aware that there have been a number of trials comparing different somatostatins and analogs, and you see here more than 2,000 patients included, and if you combine all data, we have to conclude that the morbidity is somewhat lower in the group that is on somatostatin, and the fistula rate is lower in this group. However, the hard and very important endpoints like mortality or reoperation rate, there was no difference. So you can reduce your morbidity, especially you can reduce the fistula rate, but you don't reduce mortality if you use this. And probably most of you also know this study, which was published a few years in the New England Journal, a different somatostatin analogon, pasireotide, and there were quite striking differences in the morbidity. You can see here they took together fistula, leak, and abscess, and there was a striking reduction of this in all the different groups, either in the pancreatic head resection, but also in the left resection. They could significantly reduce the fistula rate. Now, another important point is drains, and you know everybody who is doing surgery is talking about drains for different settings, and there has been a well-designed randomized controlled trial carried out at the Memorial in New York, and that had to be stopped because in the group without drains, there was a much higher mortality rate. You can see a 12% mortality versus 3% in the group without drains, so they stopped that trial, they published it, and they said, well, we need drains. And then there has been another trial in Germany again, multicentric, where they compared drains versus no drains, and you can see here no difference in the mortality and even less fistula rate in the group without drains. So the conclusion was, well, we do not need drains. So how do we come out of this two different trials? And if you summarize again all the data that is available, we have to admit that there is no big difference in mortality, morbidity, and reintervention. But it's not clear whether we just miss a small subgroup of patients that might benefit from a drain. And the conclusion, our conclusion of the meta-analysis was we cannot usually recommend to omit drains in all cases, and that's also not something we would do. What we would do is we would remove them early in case there's no increased amylase in the drain fluid. Pancreatic duct stenting, again, that's something that many centers have done and advocated. If you take all the data together, there is no evidence that duct stenting reduces the fistula rate or the mortality or the relaparotomy rate. And there's also no difference whether you do internal or external stents. As one of the last slides on the topic of how to prevent, there had been a randomized controlled trials, and the aim of this trial was actually to see if you dilute the patient, whether you could spare blood products. So the idea is you give them a lot of fluid before the operation, and then you do a strict fluid management afterwards, and maybe you can save blood. And the primary endpoint was not reached, so there was no difference in the transfusion requirement. But what was coming out of this trial was something very interesting, and again, most of the surgeons know this. There were significantly more problems in the group of patients that had a lot of fluid. You see here 7% versus 21%. So that gives the message that you have to have a restricted fluid management during surgery because a lot of fluid is associated with more anastomotic problems. And that I told you before, if you have blood transfusions, again, they're associated with a high rate of fistula. So how do we prevent pancreatic fistula? To conclude this part, well, the anastomosis technique I've shown you, we prefer a small bowel anastomosis, but you can do the stomach. There are good data showing that it's a very good alternative. Somatostatin, you can routinely use it, and if it wouldn't be a cost problem, I think everybody would use it. Otherwise, you can use it selectively in high-risk patients. There's no evidence for duct stenting. You can omit the drain, or as we would do, use it selectively. For all the other things that have been tried, like fibrin glue, patches, duct occlusion, there is no evidence. And again, at the end, try to avoid blood loss, meticulous surgery. This is, I think, the key to prevent a pancreatic fistula. So what will we do if a fistula occurs? And I wrote here something like early pancreatic fistula. So if you have some fistula that occurs within the first or second day, there might be some technical problem that you can fix if you reoperate the patient. But this is, in my experience, very uncommon that something like this happens. So most often it's some fistula that occurs later, and then the key question is it drained or is it not drained? And if it's not drained, it needs some drainage. Hopefully you have a good radiologist who can do that interventionally. If you cannot do it like this, you have to drain it surgically. And then you just wait, and in most cases, these fistula are healing by themselves. Only if you have persistent sepsis or you have other organ complications, you have to go back in, and we all know that these are the cases that have a substantial mortality. Now, I'll just show you briefly two cases. This is a patient that developed some fever on the 10th postoperative day, and there was some fluid collection here suggestive of an anastomotic leak, and he got drained, and he got drained, and he went home after 6 days after this drainage and removal of the drainage. So that's some kind of very uncomplicated problem that occurs. This is a more difficult case, a distal pankreatektomi, also with vascular resection. Again, initially unremarkable. Then you see here this fluid collection. This was, in the next step, drained. And again, he recovered. He was doing well until more or less 2 weeks, or then 3 weeks afterwards, when he was unstable. There was a suspicion of intra-abdominal hemorrhage. He got some angio-CT scan, and then there was some pseudoaneurysm, which you can probably see here, of the hepatic artery, and he got some interventional stenting. So this is leading to the final topic, the management of hemorrhage after resection. And I've shown you before that the key difference is that we differentiate early hemorrhage and late hemorrhage. If it's early on the bleeding, that means within the first 24 hours during surgery. Of course, you have to differentiate, is it intraluminal or extraluminal? I think most of these ways would go for relabrotomy. I would be quite reluctant to use endoscopy within the first 24 hours after surgery. So if you have to revise the patient, usually you have to go back in within the first 24 hours. If it's some late bleeding, and this is the main difference, you try to avoid to go back into the patient, because this is usually quite problematic to solve that problem without creating further problems. So the question again is it intraluminal? And then you would need a good endoscopist that might be able to help you. But in most cases, it's extraluminal, and then you have to go in for an angio-CT, and you have to call your interventional radiologist to perform this procedure as soon as possible. And hopefully he's successful. If he's not successful, then the only chance to save that patient is by relabrotomy. But again, you're all aware that these are then the cases that are associated with fairly high mortality. I thank you very much for your attention. I would be happy to answer questions.